We hear the phrase food is medicine all the time, right? But how exactly does a hospital meal literally save a life? Welcome to This Explainer. Today, we're taking a massive, comprehensive clinical nutrition course and distilling it down into one really engaging journey. We're going to go all the way from the basic biology of what's sitting on your plate straight through to advanced, life-saving applications at a patient's bedside.
Okay, let's dive into this. Here's our roadmap for today. We're covering the foundations of nutrition, clinical assessment, medical nutrition therapy, advanced nutritional support, and finally, clinical reasoning and evidence.
Starting off with Section 1, the foundations of nutrition. Because, look, to truly understand advanced disease states, we've got to master the basic building blocks first.
So, nutrition isn't just some lifestyle choice. It's the actual biological process of getting the exact physical materials our bodies need for health, cellular repair, and growth. And get this is a wild fact. Even if you're lying perfectly still doing absolutely nothing, your brain alone burns through about 20% of your daily resting energy. This brings us to energy balance. Basically, it's the relationship between the calories we take in and our total daily energy expenditure. Whether that balance is positive or negative fundamentally dictates our baseline health. Take in more energy than you burn, you store it. Take in less, your body literally has to break down its own tissues for fuel. It's just an inescapable physical law.
And when we do eat, those raw materials go on a highly coordinated journey. It kicks off in the mouth with chewing and salivary enzymes, then heads down to the stomach where powerful acids and pepsin just tear into complex proteins. But the real magic? That happens in step 3, the small intestine. This is where our macronutrients, your carbs, proteins, and lipids, along with essential micronutrients like vitamins and trace minerals, get totally dismantled by pancreatic enzymes and bile and then absorbed right across the intestinal wall into the bloodstream. Finally, the large intestine absorbs water and houses our vital microbiome. We really have to understand this normal pathway first, right? Because you can't fix a broken machine if you don't know how it works in the first place.
Which brings us to Section 2, Clinical Nutrition Assessment. Now that we know how the body processes food normally, we need the tools to figure out what's happening when things go horribly wrong.
So malnutrition is actually a massive spectrum. It's not just starvation. On one end, you have overnutrition, which leads to obesity and severe metabolic complications like type 2 diabetes. On the total opposite end is undernutrition, which includes really severe conditions like cachexia and sarcopenia. Cachexia is this severe, disease-related wasting of both muscle and fat. You see this a lot in conditions like cancer or advanced heart failure. And sarcopenia is the specific loss of muscle mass and function. As clinicians, these are massive red flags. We have to spot them early because they drastically bump up patient mortality, infection risk, and just overall physical decline.
Now, here is where people commonly mess up. They look at a patient's BMI on a chart and they just stop there. But a rigorous clinical assessment requires so much more than that. BMI tells you absolutely nothing about a person's actual body composition, their muscle mass, or hidden micronutrient deficiencies. You actually have to physically look at the patient. You check for physical signs like muscle wasting at the temples, or edema, which is fluid pooling in their arms or legs. You also have to check crucial biochemical markers, things like albumin for chronic inflammation, HbA1c for long-term blood sugar control, and ferritin for iron stores. Plus, you need a detailed dietary history, like a 24-hour food recall. You really have to put all these puzzle pieces together to see the full clinical picture.
Moving right along to Section 3, Medical Nutrition Therapy. This is where the science gets super practical, and we apply what we know to actually treat specific diseases.
Medical nutrition therapy is incredibly complex because different diseases demand completely different interventions. Let's say you have a patient with type 2 diabetes. The primary focus there is managing blood glucose through strict carbohydrate counting and using the glycemic index. But if a patient's kidneys fail, the whole game changes. Kidneys filter our blood, right? So a renal patient needs incredibly careful regulation of protein, potassium, and phosphorus to stop lethal toxic buildup in their bloodstream. Meanwhile, a cardiovascular patient with hypertension needs strict sodium reduction, often following the DASH diet. So yeah, there is no such thing as a one-size-fits-all hospital diet. It is highly individualized biochemistry.
Next up, Section 4, Advanced Nutritional Support. This is for critical scenarios. Think massive trauma or major abdominal surgery, where a patient literally cannot eat, but their stressed body desperately needs energy to heal.
When patients can't eat normally, we turn to two main options in critical care: enteral and parenteral nutrition. Enteral feeding means delivering nutrients through tubes that go directly into the stomach or intestines. Parenteral nutrition is different. That's delivering a highly specialized liquid mix of macros, micros, and electrolytes directly into a central vein, totally bypassing the gut. But here is the golden clinical rule you have to remember. If the gut works, use it. Enteral nutrition helps keep the intestinal lining physically intact and supports the gut's immune system. We really only reserve parenteral nutrition for when the GI tract is completely non-functional or we just can't safely access it.
And finally, Section 5, Clinical Reasoning and Evidence. Let's bring all these pathways, assessments, and therapies into the actual daily decision-making framework of a healthcare professional.
Every clinical dietitian uses a standard 4-step nutrition care process workflow to build an evidence-based plan for their patient. First, you do a comprehensive assessment, gathering all those physical signs, lab results, and diet histories we just talked about. Second, you figure out a specific nutrition diagnosis. Third, you design the intervention, maybe prescribing a specialized renal diet or starting a tube feed. And fourth, and honestly this might be the most critical part, monitoring and evaluation. You don't just write a diet order and walk away. You meticulously track the outcomes, adjust the plan, and make absolutely sure the patient is actually healing.
So, let's put this into practice. I want to challenge you with a quick case study to test what we've built up so far. Imagine you're the clinician. An older adult comes into your clinic and they've had significant, completely unintentional weight loss over the past 3 months. What do? How would you apply that 4-step process to this real-world scenario?
Well, here's how we'd tackle it using rigorous, evidence-based reasoning. First, during the assessment, we specifically check for signs of sarcopenia and cachexia. Remember those terms from earlier? We need to figure out, are they just losing fat, or are they losing functionally vital muscle mass? For the intervention, we'd probably implement targeted high-protein supplementation to protect that lean tissue, while making sure they get enough overall energy. But we don't stop there. During the monitoring phase, we continuously track their hydration, keep a close eye on weekly weight changes, and follow biochemical markers like albumin to see if our plan is actually reducing inflammation. We have to look way past common nutrition myths and rely entirely on strong clinical guidelines and constant follow-up.
Ultimately, if you take one thing away from this explainer, make it this quote right here. Clinical nutrition is not about universal fad diets. It is the evidence-based application of biochemistry to individualized patient care. From the exact second food hits the mouth to calculating a single milligram of potassium for a kidney patient, everything is grounded in hard science. So, I'll leave you with this thought. The next time you see some wild, one-size-fits-all diet claim on the internet, ask yourself, does this account for the staggeringly complex, beautifully individualized biochemistry of the human body? If it doesn't, it's not medicine, it's just marketing. Thanks so much for exploring this fascinating topic with me. Keep questioning, keep learning, and I'll catch you in the next explainer.